This is the One Thing Podcast, and I'm your host, Dr. Adam Rinde. The One Thing Podcast brings together leaders in functional and naturopathic medicine to discuss actionable information that may unlock puzzles in the areas of gut health, brain health, metabolism, and longevity. Please note, these episodes do not replace the opinion of your doctor. They are not intended to diagnose or treat any condition. Please discuss this information with your provider and discuss your own unique personal health history before adapting this information. Please subscribe to our episodes so that you can stay on top of the most current information in these areas of medicine. Hello, everybody. This is Dr. Adam Rinde, the host of the One Thing Podcast. Welcome to the next episode. In this episode, I'm so delighted to share a most amazing guest, Dr. Paul Anderson, who's been a colleague of mine for nearly 20 years. Dr. Paul Anderson is a leading voice in integrative and naturopathic medicine. He specializes in complex chronic illness and cancer care. He has over 30 years of clinical experience, and he's made a significant impact in patient care, education, and medical research. Most notably, he led the interventional arm of a US NIH-funded human research trial on IV and integrative therapies for cancer patients. As the founder of Advanced Medical Therapies in Seattle, Washington, Dr. Anderson built a clinic dedicated to innovative treatments for cancer and chronic disease. Today, he collaborates with clinics and hospitals worldwide, sharing his wealth of knowledge to improve patient outcomes. Dr. Anderson's academic contributions include serving as the professor of pharmacology and clinical medicine at Bastyr University and as the chief of IV services for Bastyr's Oncology Research Center. He's also published a book called Outside the Box Cancer Therapies with Dr. Mark Stengler and Cancer, The Journey from Diagnosis to Empowerment. His work on intravenous nutrient therapy is also featured in the textbook, a scientific reference for intravenous nutrient therapy. In this episode, we dive into a very important topic that is near and dear to my heart, which is coagulopathies and chronic disease. Dr. Anderson has dove into this topic as an educator and as a clinician and has a strong understanding of the aspects of coagulation in a chronic disease setting. In this episode, we talk about the mechanisms of coagulation, what happens when coagulation is excessive in a chronic disease state, the implications of having a coagulopathy. We talk about specific conditions like COVID-19, fibromyalgia, chronic fatigue syndrome, and also conditions like POTS, postural orthostatic tachycardia syndrome, and how coagulopathies may be a big link to why patients are not improving, and how to go about assessing and addressing people who have coagulopathies in the background of their chronic disease pattern. I think you'll find this episode very useful, very current, and probably one of the links to chronic diseases that have not been able to be solved from many different other angles. This is an area that must be investigated and must be learned about and must be applied to our patients who are struggling getting over chronic illnesses. At the very least, improving blood circulation and blood delivery and improving blood hemodynamics may help people with quality of life, and it must be done safely and effectively. And we must learn about this topic deeply before applying these topics and concepts towards our actual patients. So without further ado, I welcome you to the next episode of the One Thing Podcast. We'll jump right into the conversation. Dr. Anderson, welcome to the One Thing Podcast. It's so great to be here with you once again.
I'm excited to do this. I've been waiting for it for a long time.
Thank you. And we go back a little ways here. I think 2006 or 2007. And it's great to reconnect. Been a big part of my life and journey as a naturopathic provider and also as just in my personal life. So this is really special for me. I've waited to get over 100 of these podcasts under my belt before I would actually have the courage to reach out to you.
Oh, it's an honor to do this. And I was trying to think of how long ago it was that we met, but it was probably '06. Yeah.
Yeah. Yeah, I remember I was just starting my residency and you were the first person I was assigned to.
Yeah.
And we didn't know each other. And
Right.
I'll never forget because I had been used to a certain way of practice all through my training. And you kind of get to a point where you sort of can predict how different doctors are going to practice and what they're going to say and what they're going to do. And I remember following you into the first visit as your resident and saying, this is different. This is so different than what I've ever seen. It was like so refreshing to see how you practiced and to see the students like lighten up. Like it was like they just wake up in your presence, which is, I continue to see it to this day.
I do remember. I do remember. Thank you. I've never heard that side of the story, but yeah, I do remember those days. And I always said to everyone that I was a diversity hire for your program. So.
Yeah, and I also remember I'm not officially off call, but you put me on call on Christmas because I celebrate Hanukkah, and I think I still am on call for you.
You know, to set the record straight, Bastier put you and I both on call.
Oh, okay.
Yeah, so that was from somewhere up above, and I think it was because I was the newest faculty member.
Oh, wow.
And then you celebrated a different holiday, and so I think that's what happened. And
okay, and I think I was like, I got this, Paul. Go celebrate.
Yeah, it was. I still. There was the one infamous call that you actually called me about, and I remember taking the call at my folks' house. We were having Christmas. That was an interest, and it was the most, non sequitur kind of call you could get.
Yeah, I think I remember this. It was like a hypovolemia call. Yeah.
Yeah, it was. Yeah. Oh, good times. Yeah, but no, that wasn't Bastier put us together for Christmas. That was what it was.
Interesting. Okay. Well, as I promised you, then that day you can call me up and I'll have your back. You should have that day off at least.
That was funny.
So,
yeah. That's 18 years. That's hard to believe.
That is hard to believe. Yeah. And I would say that just to be more specific, because the audience wasn't there, there's a certain way that you practice that you brought to the students and to the school and to, sort of the naturopathic culture and as a way of really thinking as a clinician, like really processing on how things work. And how it wasn't just like, well, what are we going to give for this? And what are we going to do for this? What test are we going to run? It was always really like why and how does things fit? Can you share when that came about for you? And was that something that you just always naturally did, or did someone model that way of clinical thinking to you?
I think the short answer to that is that it's a little of both. I think my mind just naturally works that way. And part of the backstory to that made it easier is for many, many years, and I still do it some, I would teach board review courses that were both for the basic science part 1 and clinical science part 2. So I would essentially teach all of medical school in about 8 days for each of the schools. So I was constantly always having all of biochemistry and physiology and pharmacology and all that sort of reminded to myself while I taught it. And what happened was my natural curiosity in working with patients, as you know, that we get, even when I was very first in practice, it was people who other people couldn't help, or no one knew what was wrong or whatever. So I had to kind of start from not some rote, A plus B equals C, but well, you have these problems that no one has a name for, and these could be the reasons for them. And, so let's try something, or let's think through it. And then there was two mentors who I worked with when I was, really either student or very kind of new, who also used that process. And that's the way that they would think through things. Now, obviously, they didn't do that for everything, but when it came to people where everyone was scratching their head, that's what they would fall back on is, look, the body works a certain way, and it also is dysfunctional in certain ways. And maybe we can merge what's troubling them with that sort of thing. And so I think that's where that came from. And it worked. So I kept doing it.
Yeah. Yeah. And, also, you're the way you teach, and I'll never forget, coming out of one treatment room, and, the students were, it was a, condition, say, for hypertension or what have you. And the students were saying, yeah, we always give this particular supplement for that, the supplement name. And I remember you stopping and saying, well, what's in it? And, and students were, shrugging their shoulders. I don't know, but it works. And then you said, well, let's look at the ingredients and figure out like why it might work and what, and so what came from that is, really just a process of to really be methodical and precise with what we do. And it brought to me a level of professionalism to the community and to the school that we hadn't seen. And other providers were amazing and did their own things that were very helpful. But it was just a different wave, and you can see that the generation of practitioners that you've influenced are, many of them are in the prime of their career right now.
Yeah. Well, thanks. I'm glad I was able to do that. And as you know, I still teach a lot, and I think it's just because I really love doing that. Teaching patients, teaching doctors. That's my thing.
Yeah. And then another kind of personal note we'll get into in a little bit, but I want to hold that for a second, is just to hear more about what you're up to today and kind of the things you're most passionate about at this point of your career.
Yeah. So currently, so just for the sake of timelines, I realized earlier this year, this is the 30th anniversary of me teaching in the naturopathic schools and in the integrative medicine space. So I've been at this a long time. So the way that I divide my time at this point is I have a private practice that is kind of hand selected one direction or the other of patients with. I've always had chronic illness and people with cancer, kind of 50-50-ish. And that's currently the mix. And then the rest of my time is spent either educating doctors, and that's in kind of the broad sense, healthcare providers, really more than just doctors, in the integrative medicine world, naturopathic world. And then now a little more like what you're doing, patient education. So I do a lot of patient ed videos and things like that. So that all keeps me very busy. I, like you, I write. I've got a number of books and a lot of more peer-reviewed publications. I've done that before, but for whatever reason, I've been involved in more of that lately. So I'm nowhere near being able to retire or want to. So I stay plenty busy.
Great. Yeah, so your work with cancer, we can see over your shoulder here in the video, a couple books there that you've written. And I'll say, you were there for my son in a very critical time in his life when he was going through neuroblastoma treatment. And also you work with many kids that are going through cancer, and Lily, who's sort of one of the children you helped, Lily of blessed memory. And I just want to thank you for being there at a time in my life when I didn't have providers to turn to that would go to bat for me and my family and for Jordan, my son. And, there's heroes out there, and you're one of them. And, it's just really grateful for all that you've done for kids and for my family.
Thank you so much.
Yeah. So as we talked before, we're going to be going into a little bit of a lighter topic, or maybe not for so many people, but, I reached out to you and I really wanted to go through like a dive about coagulation with you, because this concept of hypercoagulation was introduced to me early in my career and just sort of like at the tail end of my training. And then I met, I'm sure you remember Fry Laboratories from back in the day. And I think they've closed since, but I started remember getting videos from the lab, Dr. Fry, about all these connections between coagulation and biofilm and chronic disease and many of the population we were seeing. And it sort of opened this world, but at the time it was sort of, I was just at basic level of my career, and then full circle, with what's happened with long COVID, this world has become front and center for me. So that's kind of why I reached out to you. And I just thought, maybe we could start off with just generally like when you started thinking about this pathophysiology, if we could call it that, of like blood coagulation issues, hypercoagulability in chronic disease.
I think that in a sense, it's always been a little piece of chronic illness thinking, and certainly a more well-known phenomenon within people who have cancer. So, kind of always been aware of these abnormalities, but probably coinciding with maybe when you were first out and hearing about it, just a little bit before that, maybe 5 years before, 4 or 5 years, there was this sort of big, I don't know if you would call it a renaissance or whatever, this upsurge of information about chronic disease and coagulability. And it was sort of like it was not on the map, and then it was on the map. And I knew Dr. Fry, reasonably well back in those days, but there was lots of people talking about it. And, kind of to the point you were making earlier about the way that I think about things, whenever there's something that suddenly appears out of seemingly nowhere as a medical phenomenon, my first thinking about it is not so much that I doubt it or whatever, but I always take a step back and say, I bet there's a lot about this we don't know. And, and so when it ever comes sort of fully packaged, and it's like, all you really need to do is get people on sublingual heparin. Okay, because heparin we normally have to inject and all that. And, back in those days, and some people, with migraine and some other things, would get a lot of benefit out of it. But I remember there was it was a doctor probably preceded you by about 5 years, and they were new in practice, and they were thinking, oh, this is great. And I remember that, they had patients that were having, too easy bleeding because they were getting so much heparin, and they really weren't helping whatever their underlying things were. So it kind of came from there, and I just kept thinking, I knew the kind of the cancer side of it, which is its unique thing, but it's very related to the reasons we see it in chronic illness. And I kept thinking, there's things we don't see right now. Like there's stuff we haven't either discovered, or we don't know some genetics, or there's some other stuff. So I saw it as a phenomenon, and in cancer patients who would sort of deal with it one way. Chronically ill people, it was like, well, we can try these things, but the testing really was pretty rudimentary back then. Really, the type of tests that we can do now are very, very different and much more specific. So that's kind of where it started. So it was always there. It was always something I was thinking about. And then I would say, fast forward to about 10 years ago, because of the crossover in cancer, I started to teach more about it in regard to your patients who may have cancer, even if they're in remission, et cetera. They're a little more likely to maybe have some of these clotting things go on, which can create other problems. And so then we had a little bit better testing, and we started to sort of extrapolate that over to our chronically ill population. And I think what changed a lot of it for the rest of the world was COVID. because suddenly we had a collusion of a few things. One is we had a whole bunch of research that got funded because of COVID. We have this big black box called COVID, and we got to figure out why people are sick, why they can't get better, all this stuff. So that's great. But all of a sudden, there's all these papers about all the immunology behind lots of unfortunate things. The next thing that colluded was, and I saw this coming because I had been working with chronically ill people forever, is this I saw, well, this is the kind of a virus, this is kind of the illness that is not going to just come and just leave the person healthy on the other end in many cases. This is going to come. It's very disruptive to the immune system. And if you have maybe the wrong set of, underlying either genetics or diseases that are smoldering or whatever, that disruption of your immune system is going to leave you with microclots, or it's going to leave you with, damage to certain cells or whatever. And I think fast forward a couple of years into COVID, and then people start writing about that. So it's like, this is the first time really in a chronic illness setting, it's recognized widely, even though people debate about, long COVID and all that, but it's recognized widely. And there's probably more research specifically about it. So I feel like COVID's something I wish never would have happened, but from the point of view of bringing this research together and us understanding how these things happen, I really think the research into why COVID behaves the way it does is a big part of that. So it's sort of the evolution of my thinking.
Sure. And I mean, you to kind of go into what you were hinting at, I mean, you've been treating chronic fatigue syndrome and fibromyalgia for years, and this kind of that world showed a lot of this, right?
Yeah, it certainly and I think the thing underlying that is in chronic fatigue and fibro patients, almost always they had other chronic things that maybe were undiagnosed. Could be autoimmunity, could be infections, could be all sorts of stuff. So there was always this immune dysregulation that would lead to your blood coagulating in ways it's really, it shouldn't. That would then lead to, organs not working right, et cetera. So yeah, it just, I think the big difference is when you get to COVID and then long COVID, it's like we went from nobody wants in standard medicine, nobody wants to claim and deal with chronic fatigue and fibromyalgia. Every specialty pushes it away. And with long COVID, it's sort of like, well, this is a thing. We're not sure who's going to deal with it, but it's a thing. And we have a ton of research, and it's named, and it's, cataloged and all that. So it's not really as different from what we saw all those years ago. It's just, it's indexed better now in the immunology literature.
Yeah. And, it's, to kind of finish up with that, and then we'll probably circle back with it, is this, that, like that was sort of a big jumping point in understanding long COVID is when, the research out of, I think it was like South Africa that talked about, they were doing flow studies on capillaries looking for microclots, and they kind of saw this phenomena of hypercoagulability. And of course, there was many advanced cases of COVID that showed that. And so it's really interesting. So backing up a little just to kind of set up the understanding, sort of people understand the word clotting, but there's many different components of it, or coagulation. So just from a basic standpoint, the difference between like thrombus and fibrin, or that kind of division. Can we maybe go into some basic descriptions of what we're talking about with the different pathways of coagulability?
Yeah, I think that's a great place to start, actually. So many people know, but a lot of people may not know, is we have built into our systems, and every mammal I can think of does as well, two-armed coagulation pathway that's all chemically driven, right? And so we have an extrinsic pathway, which is pretty simple. That's when you cut yourself so that you hope to clot, right? So that's the extrinsic. And then we have an intrinsic pathway, which is more problematic in many health areas because it doesn't take a cut to trigger it. It can be due to blood flow turbulence, like say you have a bad heart valve or maybe a big plaque in the artery or something. And those two eventually they start separate because they're triggered by two different things. One is cutting you, and the other is blood flow abnormality,
Mm-hmm.
and they come together at a place we call the common pathway, really factor 10. And what they do after that is the same. It's to create a clot. So the first thing about it is each step, and there's many steps. There are many, many steps, and we discover
Yeah.
more all the time. But each of those steps has different immune chemicals, different cytokines that will tell either the enzyme or the promoter to turn on. And the crossover that often gets overlooked is those happen to be, in many of the steps, the exact same immune chemicals that, say, rise when we have like an acute infection. Or in the case of COVID, and COVID's sort of the poster child for odd immune activity. In COVID, it may rise and not do the normal thing, which is rise and go back down, but it may rise and stay risen. Okay. Which, especially with the early variants of COVID, is why people would be in the hospital and unable to breathe and all that. So it's that chemistry that we think of as running our immune cells, which it does. But when we derange it, if it also helps us to turn on clotting, it just keeps turning the clotting on. So one of the ways the body does this, which is really quite amazing, is when you need to clot, you want to have the makings of a clot ready. Okay. The problem is you don't want to clot all the time, so you want them in an inactive form, right?
Mm-hmm.
So what our body does, which is very wise, is it makes all of the, I call it the fixings for, making a clot, and it makes them in an inactive form. And it even makes the activators in an inactive form as well. So they're floating around, but we don't clot all the time. Otherwise, we would not be alive. It would not be compatible with life. But if I cut myself, I want all those inactive things to suddenly flip over, turn on, make a clot. Well, there's a whole bunch of them, but I think the two that you brought up, the first thing is there's a step called thrombin, okay, near the end of the common cascade. And thrombin goes down, and it helps to form something called fibrin, and fibrin is a fiber, as its name would go, which, along with platelet release factors and other stuff, goes in and makes actual clot. Well, we don't want a lot of thrombin floating around, or we'd just be clotting all of the time. So we have something called prothrombin, and it's just floating. And if we don't need it, and again, this is after both pathways come together, the prothrombin will just keep circulating around, and it's not going to hurt you. There's a thing called prothrombin activator, which is kind of all the factors from X and intrinsic. When they come together, they make prothrombin activator. So that turns prothrombin to thrombin, and as soon as that happens, thrombin goes to the inactive fibrin called fibrinogen and converts it over to fibrin, and we just start making clots, right? Well, all of that is pretty much signaled by immune chemistry. So the way that I've explained it to patients with long COVID, or sometimes family members with a patient in the hospital, is your immune system is getting unusual signaling in COVID. One of COVID's hallmarks is excessive interleukin 6, which is one of the big drivers there. And interleukin 6 is supposed to go up when we're sick, and it's supposed to go back down rather quickly, so we have an immune response, but we don't have too much. In COVID, in every strain they've looked at, or variant, the interleukin 6 can go up and just not go down, right? And what we saw in people who were hospitalized, which are the first people, of course, they were doing studies on, was things like interleukin 6 and certain other ones, which all correlate to clotting, all immune plus clotting.
Mm-hmm.
These things would go up and they would just kind of stay up. And so this is why people go into respiratory distress, or their lungs, would start to have fibrin deposition, or the kidneys would.
It's
yeah. So
the ground glass appearance.
Yeah, and especially like with the original, wild strain, and then the first couple of variants, that was really really bad, as people know. So I think that's a good way to think about it. Is our body is ready to clot, so that should we need to, we can clot. It's triggered by traumas, but the traumas get perpetuated down to this common pathway by immune chemicals, and your clotting cascade has no idea that the immune chemical came from an infection or you getting cut. Like there's,
Mm-hmm.
it's not a differentiation there, or
Mm-hmm.
due to a bad heart valve even. So imagine if you have somebody who's already kind of a little more pro clotting, a little hypercoagulable for other reasons, and then they get a chronic illness, or they get a more exacerbated version of COVID that goes, kind of
Mm-hmm.
too far, or they have, mast cell response, which nowadays is much more common. They suddenly will just go from they don't notice anything, although they had trouble, to now they're having microclots and maybe macroclots, which are causing your brain won't work correctly, your kidneys won't, nothing in your body will work correctly. So I think that that's an important thing. It's sort of like your body's trying to do the right thing and it's getting bad signals. Um,
Yeah. Yeah. So let's go into that because that was really clear. Thank you. And I think, just seeing this sort of overwhelm of the system and sort of a pro coagulation environment, but we have some defenses in there, right, that work to try to control and break down this fibrin,
mhm.
right? And, person A versus person B, what might be going wrong with that system? Why do some people have the ability to keep up with all this production? We have inactivators of fibrin and fibrinolytic pathways as well, right?
Hmm. Hmm. Yeah, and that is one of the things is anytime your body has to go into a disease response, normally there's something to shut it off, because otherwise you would clot forever and ever. So the body has ways built in to oppose, this. It's a balance. So you don't want to oppose it so much that you don't clot, but you don't want to clot and then keep clotting and, clot some more. So it's important to keep in mind that those factors, you could call them either the clot attenuation factors, or the fibrinolytic factors, or whatever. They come from almost as many places, chemically or immunologically, as the drive to clot. Okay.
Hmm.
So one place that they can come from, and depending on genetics and diet and health and all that, this is more or less in each individual. But one place, and it's a target nowadays of certain types of drugs that might be used, but is the reactivity of the platelets. Okay. They call platelets thrombocytes because they help to make thrombus or clots. Well, what platelets really are pieces that come out of the bone marrow that are full of these granules. Well, what's in the granules? In the granules are a whole host of triggering molecules to create inflammation. And so the platelet will come along. We've had fibrinogen turn into fibrin. And in that process, the platelet will bust all these granules out, and it will create more of a matrix to make the clot go faster so I don't bleed to death. So the anti version of that would be if the platelets have a reasonable amount of stability in their membranes, they will not overdo that. And the stability comes from some basic things: vitamin E content, which is helpful also in other cells, but vitamin E content in your blood, things like omega-3 oils from our diet, and a few other things. But those are very important. And one of the things that can cause, now let's just blame COVID because it's an easy target, but it does it better than anything. Let's say you had COVID and you didn't know your platelets really were already inflamed. You weren't clotting maybe, but they're just ready to touch off, like dry kindling. Well, the platelets then have no reason to go into sort of an antiplatelet activation. They'll just keep dumping out the inflammatory chemicals. Same thing happens with the fibrinolytic enzymes, the ones that can come along and help to say, okay, we've got enough clot here, and so we're gonna kind of shut off the fibrinogen to fibrin conversion and all that. If I'm really inflamed, which could be chronic illness, could be autoimmunity, cancer is another one, any chronic issue, the enzymes that are going to help me not allow the clotting to kind of progress, same story as the platelets. They're not going to be around for me, basically. And those are only a couple of areas, but those are areas that are often, clinically targeted in people. And whenever you want to bring it in people, even relatively healthy people, but they're having a little lingering COVID activation, long COVID or post-acute sequelae. Clinically, there are ways that I try and have that patient, do things to kind of prime the pump so that we get back to the normal, non-inflamed function, basically.
Okay. And so along those lines, since, you're someone who does a lot with like genetics and nutrigenomics, and any comments about just susceptibility or risk factors for having issues with susceptibility for fibrin buildup?
Yeah, I mean, and there's so much more in that area that we know now than we did 5 or 10 years ago. One of the things, I use the example of somebody who feels healthy, believes they're healthy, but then they get some insult and they clot, inappropriately. Usually there's something causing everything to be on edge. So we have a system that wants to clot when we need it, doesn't want to clot, but it's tipped towards the let's clot side of the equation. One of the big areas for that can be genetics. And so a lot of the steps in the clotting cascade are called factors, which is nice because it's different clotting factors. There's a few, each of them is coded by genes, but there are some like factor 5 that is a very common heritable genetic problem. People, hear about maybe the more common diseases where you don't clot, like hemophilia, where you have different factors that, aren't made or incompletely made. Well, in some cases, upstream, you might have like a factor 5 genomic problem. And so it's always going to be dysfunctionally active and maybe trigger all of its friends below it more quickly. A lot of people, and I know I saw this, especially in the, we were doing more genetic testing in the chronically ill community. So it's a little bit of bias there, but we saw a lot of people with factor 5 and other type of genetic abnormalities in their clotting cascade. And what it does is, under normal circumstances, maybe you're not doing a lot of clotting, but it doesn't take much of a push if they're abnormal to turn them on. Whereas, your cousin who doesn't have those genes, it takes a bigger push to have the clotting go on. So genetics is a huge thing. And if you consider, all those two big arms of the clotting cascade and the common factors, each of those steps have genes that code for them. And nowadays, there are much more well mapped out, genomic sequencing that can be done for, especially people with, real unusual clotting that doesn't make other sense.
Yeah.
So,
and
yeah.
Yeah, and it's interesting because most people find out that they have this gene after the fact, which is unfortunate because, it's like someone has an early termination of pregnancy and then they'll find out maybe they have factor 5, or someone will have like a stroke and then they find out later, like afterwards. It's just, for stroke prevention and just coagulation related issues, it seems like it would be more of a good plan to have those things early on our radar.
Yeah, I would say very definitely. And I think in general in medicine, if you consider how rapidly testing has evolved, both in just looking at the clotting factors in the cascade, that how we could do it now versus 10 years ago, and then also this genetic component of actually being able to test it easily, used to be extremely hard. If you put just those two testing platforms together, they can give you so much information for prevention. But because of the way doctors generally are trained, if that wasn't, if that didn't magically happen during their residency, it may be much later in their career before it, it kind of comes around again. And that's what I see a lot. It's like, I mean, I personally don't know too many doctors who would be against prevention of things like strokes, etc. But you get ingrained with the idea, well, this is how we do that, right? And it's sort of like, well, that's how we did that 15 years ago, and we could maybe
Yeah.
do better now. Yeah, and I guess just to put a point on it, things that one would do to help, like calm the platelets down so they're not so hyperreactive, and bump up the fibrinolytic, enzyme activity and all, and help the rest of the cascade. If somebody has any of those clotting, genetics, and maybe some of the early other testing we might do that's positive, you want to be proactive about saying, look, you're just trying to clot, okay? You might feel really healthy. You're 30 years old or you're 40 years old, but you're going to live a long time, and we don't want a ticking, clotting time bomb going on. And again, I think that in some people, in a negative way because it created pathology, positive way because maybe they got testing. COVID has pushed us forward a bit in that there are people who've clotted, and then they sort of reverse engineer the testing and say, oh, well, you were waiting to clot. But then there's also people who maybe have long COVID, got into the right program, got the testing done. It's like, gee, you don't look like someone who would have a stroke, but you're waiting, to have that. So why don't we do something about that proactively?
Yeah.
But yeah, I think it's just, medicine changes like a glacier, and this is an area that would be nice if it sped up.
Yeah. And I want to circle back at the testing and indicators and things like that, and just kind of go into, this concept of how someone presents in general with symptoms or of hypercoagulability, that like when you're sitting in front of a patient, and I know the complex cases you see, and I always think about like you're the master of puzzle building and puzzle assembling, and I always think of what makes Dr. A pick that piece of the puzzle on the table and say, this is looking a lot like a coagulation issue, versus just saying, well, these conditions are associated with hypercoagulation, so let's open that door. What would the patient look like to you that's like jumping out, and symptoms they're having, like when it's maybe below the surface and not like above the glacier and really standing out?
Yeah, because I mean, obviously, if somebody's already had a problem, it's kind of obvious there. I think that there's a few things, and it's, think of it sort of like a small, medium, large approach. But from what I have seen over the years, just it was almost kind of by accident, because we're doing so much genomic testing with people with chronic illness, and to see how frequently clotting factor abnormalities would come up. That sort of got my attention, that, oh, this population, that, thank God, no strokes or anything, but they could really easy, right? So I think one thing is, how do they present? So do they already have even a smoldering chronic illness, etc.? I really think now, based on seeing a lot of tests on those folks, I think that at the very least, the basics as far as genomics around clotting, and then a deeper look into clotting function, which can be done by various testing. I think those things are good screening tools, because you're already with a chronic problem. And again, whether you could say chronic fatigue fibro, but also almost any autoimmune condition. Now, there's some autoimmunity where you don't clot well, but most do clot too much. Anybody with a history of cancer, meaning anybody, even if they're in remission, because remission doesn't mean that your body forgot some of the bad habits. So the baseline is there any smoke that might be a fire, even if you feel relatively well? The next level would be, this is maybe more sneaky, maybe not, maybe it's more obvious, but it's the group of people who were feeling really super healthy, and then they got something like COVID, but COVID's kind of the best example, and they just can't quite get over it. Like things aren't, they, and maybe they're not bedbound, but they're post acute sequelae, meaning just long COVID. It's like it's just nagging. It's just it won't go away. They're not themselves anymore. They don't have the exercise tolerance they used to. All those things, or now they have chronic headaches or not whatever. I would say 100% of those people would now fall into the other group, which is you have something going on. And if you don't have clotting, issues, great. It's good to know about it. Like at least we tested. But so many of those people will go on, and a lot of the exercise intolerance is literally due to damage to the lung membranes, etc. Or there's many other things that go on. So that's sort of kind of the next level is I was healthy, I thought, then I get this thing, and now I can't get back to normal. I just can't quite get back. And to give equal time to other illnesses, because it is in the research. We always saw that with influenza, and we always saw it with other viruses, just not in the quantity of people that we see it with COVID, right? So other diseases. And then there's things like maybe you are healthy, maybe you didn't have a problem with COVID, but you have some other tell. And that, as you mentioned, that could be maybe a history, miscarriage, something like that. But also family history. You're a young, healthy person. Your lifestyle is very different from your parents and grandparents because they had cardiovascular problems or strokes, etc. But maybe there's genes that you carried with you that you're beating back with your diet and lifestyle. But it'd be really good to know that maybe you need a little bit of extra help there. So I think, it's, and then everything beyond that is someone who's already had, a problem that you would say, oh, yeah, you've already had a problem. And so, it's changed a lot from what we used to be able to do, which was to run originally APT and then PTs, and then we got PTINRs, big step up, and no one, except the hematologist really understood those anyway. And then we started to be able to run, fibrinogen, and now we can run fibrinogen activation, and now we have these big panels that we can do, and specific genomic panels. So I think that a lot of people just don't know what's available, that might help them with prevention. But if I was, let's say I was speaking to a group of the public, and they said, okay, which of us should probably look into this? It would be those groups of people, anybody with a chronic problem or history of cancer, and then anybody who was healthy and then got knocked down by some infection and can't get over it, and then family history would probably go in. Yeah.
Okay. Yeah. And, I think there's like some soft signs and symptoms that, you would hear also to kind of add into that. I'd love to get your take on it. And these are really difficult because they're general symptoms, and they're also hard to really, you have to be a very astute clinician to pick these up accurately. So for things like capillary refill on physical exam or cold extremities, and some people will say they have Raynaud's, and they're conditions that kind of present in a way with coagulation. And what do you think about those as being soft clues? Is that something that you would validate?
Yeah, I think I'll start with the most obvious one. So you have somebody who says, I think, or I've been told I have Raynaud's phenomenon, and that's where you'll actually have blanching of the fingers and the feet and the toes and stuff, and usually under cold stimulation. But if you go back to basic pathology, there's Raynaud's phenomenon, which is by far the large thing, which is idiopathic, meaning we've not figured out why. And then Raynaud's disease, which is associated with another trigger that is known, such as cancer or some usually bad things. The problem that I've seen with people is a lot of, again, if we now go into the chronic illness community, a lot of those people have Raynaud's, and it's just like, well, it fits the picture, so we'll tell you have Raynaud's, and there's nothing to do about it, except don't get cold, right? Or maybe take magnesium. That's the other recommendation. So I think in anybody like that, and then you could go to other things. Anybody with erectile dysfunction, for example. Think of other blood flow problems. vascular changes in visual function, which do happen, vascular changes in mental function, which can
Mm-hmm.
create brain fog or pseudodementia or all kinds of. And also, this is a little more subtle and not as common. But people whose kidney function was always really good, and maybe after an insult or something, it just went down, and
Hmm.
it's stable, but it's at a lower level. What you kind of think back to is that could be microclotting, which
Okay.
now, thanks to COVID, everybody kind of knows about microclotting. The problem is that, well, that's a real issue, because now I've got the terminal ends, whether it's my fingers or my brain or my eyes or whatever, where I've got microclots. So there's blood getting through, but it's not as good as it used to be. So whatever that organ does, it's not going to work as well as it would have
Mm-hmm.
before. So yeah, I think that those soft signs, especially nowadays where we actually can check more than we used to be able to check. I think those are worth working up. And again, that plus family history, or that plus a chronic illness, or that plus something else, it's just more reason to do it. Really, yeah.
Yeah. Okay. And before we leave this little segment here, I would just kind of like to get your thoughts on coagulation or hypercoagulation scenarios leading to dysautonomia, because I see that come up quite a bit, like in the POTS community, that perhaps the reason we're having a lot of these dysautonomia symptoms is because of hypoxia and hypercoagulation connections.
Yeah. So in the world of, you know, especially something like POTS dysautonomia, although it's certainly been known, for a long time, I would imagine even the average healthcare provider hasn't heard about it, as much in the prior 30 years as they have in the last 5 years, right?
Right.
And part of it is awareness, part of it is better diagnosis. I remember 15, 20 years ago getting people diagnosed and the machinations they would have to go through, and then sometimes they'd get a diagnosis and often they wouldn't. But there's it's interesting you asked the question, because I'm in the middle of putting together a training for doctors about this collusion between dysautonomias like POTS and then inflammatory triggering like mast cell disorders and
Mm-hmm.
that family of things, and then even hypermobility syndromes, all of which are much more commonly seen now. And if you think about what would take a person, and because you see this in people, it's like they may have had no symptoms and all of the sudden they have this dysautonomia where they stand up and fall down, or all of the things, right? And they're having to pound down tons of electrolytes just to kind of keep their blood pressure level. Well, all of that is largely triggered and auto-regulated in the lower portions of our brain, the parts that keep
Yeah.
us moving. Those are areas that are your whole brain needs blood flow, but if you take those little tiny areas, which are basically little receptor areas that tell us whether we're blood pressure is good or not, all that stuff, and then it's supposed to feed back to our autonomic nervous system to keep us from passing out, for example, hence
Mm-hmm.
dysautonomia. Well, if we have microclots in those areas and I only have a limited number of these little tiny receptor areas, it's like a computer and taking certain pieces out, the logic gets all screwy. So you got a person who didn't have it and now boom, they do, right? And then if you overlay any other stress on top of that, whether it would be, say, COVID or a mast cell stimulation or just allergies or other infections, it makes it's sort of like POTS on steroids to have that happen. And, interestingly, there's a paper that was literally just published in the world of research anyway. And it said, well, is there any difference between long COVID? They use different words, but long COVID and POTS, and if I have them together, is it worse or not? It's an interesting paper in that both are bad. Okay, both leave you with a lot of bad
Mm-hmm.
things. But for whatever reason, the researchers didn't actually look at the criteria that would measure the POTS part of it. So what they said is, well, they're both equally bad. we don't know, we should study this more. But they didn't actually look at the dysautonomia part of the thing.
Mm.
So if you look at the title of the paper, it's like, oh, POTS and long COVID, no problem. That's not really what they're saying. So what I have seen, and I have a patient currently who is just on the tail end, thank God, getting better and all that. But the inciting event was not the pregnancy so much, although I think that got them ready. They were super healthy. They're young, all of that good stuff. But they had a very traumatic, extremely traumatic labor and delivery, a number of other kind of coinciding unfortunate events that went on right around labor and delivery. And on the other side, they developed the most profound dysautonomia. And one of the things that goes on in especially traumas in labor and delivery is an alteration in clotting and all of that. And, it's about 14 months worth of really intensive kind of work to unwind it. Because first you have to keep them stable just so they don't pass out all the time. But lots and lots and lots of work. And finally, they're kind of 80-90% kind of back to themselves. But I know from some of the testing, and I know from the way it looked, and especially the history of like healthy, no problems. And the pregnancy really wasn't that stressful. And then big traumas, clotting dysfunction because of trauma and pregnancy. I know that, probably microclotting, et cetera, became a bigger part of the reason that all that dysautonomia came on. And it, disruptive is not even the right word, like life altering, and thank heaven they're really on the other side now. But yeah, that's we're seeing that more. And I have a feeling, because just to tie a bow around it, the things that the platelets have that would trigger a lot of clotting are real similar to the things that the mast cells that we think of in allergy phenomena.
Yeah.
Well, in the world of COVID and post-COVID, mast cells are always on edge and ready to help the platelets do the wrong thing, right? So if you put those together, it's no wonder that those people develop POTS and vice versa.
Yeah. I was sort of reintroduced to this topic also by someone named Ruth Chris, who's a nurse practitioner who's really works with chronic urinary tract disorders. And, her big thing is this world that we're talking about of fibrin production is really associated with giving bugs the ability to form biofilm. And I know, like, you've developed a supplement and protocols for addressing biofilm. You've talked about it for years, as sort of understanding how biofilm works. And that's like a whole other webinar podcast. But I just love to hear your thoughts of how bugs take advantage of fibrin.
Yeah, that's a huge thing. And I guess one of the people who made me feel not crazy around biofilms was Dr. Fry, because he used to study them.
Yeah.
And that's probably why he and I sort of were simpatico. But the short answer is that biofilms exist in all of nature where there's water, right? And in us and other mammals, it's largely mucous membranes, which is respiratory, digestive, genitourinary, etc. And the biofilms are on a spectrum. So we all have normal ones, just like we have normal bacteria in our gut. We have normal biofilms, not a big deal. But there are certain bugs that are biofilm formers, like Pseudomonas. And you think of anything that's hard to kill with antibiotics, it's probably a biofilm forming bacteria that works almost always, right? Well, if they happen to, let's pick on Pseudomonas, if they happen to be in your eye or your respiratory system or your gut, and they start to grow, they just do their thing and protect themselves by making a biofilm, which is sort of like building a hive. Well, pieces of the hive, if you have extra fibrin that can, again, you're kind of pro-clot, you don't know it. You have these microfibrin productions. Their inflammation triggers the formation of fibrin faster. and they use it to form, a bigger, better hive, right? And so, in a lot of things, chronic urinary tract infections is a huge thing. Chronic respiratory, chronic GI things. Biofilms are often behind that because they're literally hiding most of the bugs that are doing it. And I think that this is another reason that we see it's just so much more common in people with, chronic diseases where there's these smoldering chronic infections. The biofilms are nature's way of protecting that bug. And if it's a bug we don't get along with, then it's a pathogenic biofilm, basically. Yeah.
Mm-hmm. Okay. At this point, I think it's good to sort of talk about, what one can do about these issues if, they've been evaluated and worked up, and or there's really strong evidence that hypercoagulability is taking place. What can you do, and what do you have to monitor, going forward?
I think it's always good to think of, either prevention or maybe you've had some problems and you're trying to unwind it. Either way, in steps. So the first thing would be looking at, my diet, my lifestyle, those things. Is there something I can modify and mitigate that would be the base, right? Because there's always drugs and supplements and things on top. The things that I think move the needle the most, would be anything that would decrease my inflammation generally. But one thing, and this is actually coming out now in cancer research and other, kind of things that cross over with coagulation, our base level of hydration actually makes a huge difference as to the ability for inappropriate clotting and inappropriate other things to happen. And, it's almost like, and this is like the paper about cancer just published last year, and hydration's become a thing now, right? But what they're looking at is not so much, global hydration. At the cell level, if I don't have enough water moving through my body, I basically don't move enough water through my cells and then back out to kind of take the trash out of the cells. So the extracellular milieu becomes more inflamed. Well, that's the last place you want that, because that could be the inside of your blood vessels or your lungs or something. So actually hydration makes a huge difference. Diet, and there's lots of ideas about diets and things like that, but dietary a dietary intervention for yourself that would be the lowest triggerer of inflammation. So exclusive of things you're allergic to or sensitive to, which you shouldn't be eating anyway. The diet with the most research around inflammation would be a modified Mediterranean diet. That's a very common thing we prescribe for folks. And part of that's, the oils are a little better, but also there's a lot of polyphenols and other plant chemistry. And it turns out that the polyphenols in plants and flavonoids and all those other goodies that make the plant colorful calm down the platelets and the mast cells so they're not so inflammatory, but they also go into other pathways that would help me not clot. So diet and hydration do become very important. Moving your body. Now, some people say the E word, which is exercise, but that scares some patients, so I call it movement. It actually physically helps you to turn your blood over more times during the day if you just move a little bit more. And your liver especially, but your spleen also, will get more blood through it. And they can then take some of those pro-inflammatory triggers. So there's other stuff like sleep, et cetera. But so what you can do that doesn't cost you a thing, eating and hydrating and sleeping and all that. The next thing, though, which now I do this a lot more now because of long COVID, but I always did it in my chronically ill people with clotting problems. I will now do sort of a stepwise increase in supplementation. So even if they're eating really great, I will probably have them doing some amount of vitamin E, because that's another thing that all of our things that are either pro or anti-inflammatory that float around in our blood, vitamin E keeps them more on the calm side. So vitamin E, and you don't need a ton, just the right amount. Uh, Normally, omega-3 oils, because they kind of push us more towards not doing, not releasing when we shouldn't. And then in the world of long COVID patients, because I have seen more clotting, I don't know, probably 100 times more than what I used to do this in all my most of my cancer patients and the real sick, chronically ill, but now more people, is something to help with the fibrinolytic system. So you could think of like nattokinase or serrapeptidase, or these are enzymes. We just have people take them first thing in the morning. And if they're real acute, I have them take them 3 times during the day, because those actually oppose the microclots and they help you, with the breakdown side. So one of those types of like nattokinase is the one everyone knows about, but there's a few there. Lumbrokinase is a cousin, and depending on who you believe, maybe it works better. And then, above that, depending on how bad things are, I have a fair number of long COVID with clot, either history or we found it, on baby aspirin. And what baby aspirin does is you think of it working sort of on the periphery of clotting to just force the issue with platelets and some of the other things. And I don't necessarily do that forever, but I would rather prevent microclotting and help them break it down, and when they're all better, maybe take the baby aspirin away, than have somebody just keep collecting little clots. And everything after that becomes a bigger intervention that usually requires prescriptions and monitoring and other stuff like that. But that's kind of how I build it up. And like the young woman I was telling you about with the postpartum trauma and the dysautonomia, or others, until they're out of the woods, we kind of really do all of it, and then back off as we get to the other side.
Yeah, and it's interesting with the biofilm connection is, a lot of times when I'll start people on lumbrokinase or nattokinase, they'll actually have like a Herxheimer reaction, or which in lay terms, it's kind of like a die-off or reaction where you feel kind of nauseous or brain foggy. You can actually feel worse. And, it's come to be expected now for me. I wonder if you could comment on that.
Yeah, well, one of the things that happens that often, unless they know they have a problem beforehand, is almost all of these things we're talking about, but like the enzymes we take orally. And people, there can be biofilms in your bloodstream, they can be everywhere, but most of them are in your GI tract that cause the biggest problems. Well, imagine if you incidentally, to try and help you not clot, take an enzyme that also starts to break down, some of the fibrin strands and stuff in the biofilm. What happens is that suddenly the gut immune system sees microbes it hasn't seen before, and it tells the systemic immune system, and basically the systemic immune system overreacts because they were hidden. Now we've opened up the window a little bit, and the immune system says, gee, we didn't know these were here. We're going to have this big immune response. A Jarosz-Herxheimer reaction or something like it that's different specificity is the body basically overreacting because of the presence of something it didn't realize was there. So you do always want to warn people in the beginning, hey, any enzyme I give you, if you get, achy or a fever or you get other stuff, let me know. We may have other things to deal with there.
Yeah. It's really great when this does work. Helps, kind of. Yeah. I always think of it as like a step system, where like this is, a big step in the healing process. Like it may not be the whole thing, but it's, like a big leap to get to the next layer of healing, or So, yeah, I think that really was a really great run through. Is there anything you'd like to also add to this? And then, I'd love to hear some more about things that you'd like us to know about, books, courses, conferences, things that you're doing. Of course, we'll put links to your website and all those things in the show notes. But anything else you'd like us to know about this topic, or any takeaways and things that you'd like to share with the audience?
I think probably the number one thing, as maybe a parting word, is during, COVID's still going on, but during the earlier days when things were very bad and people were more likely to be in the hospital and dying, um, on top of my regular practice, I had a lot of acute COVID care I was doing, and also because of some things I've published about other stuff, I was doing a lot of consulting with ICU directors around the U.S. Usually at the behest of the family, not because the ICU director wanted to talk to me. So I really have been involved with people at all stages, but usually not great stages of that disease, and now long COVID. And the thing I think's most important at this juncture is, whether it's COVID or whether it's like my patient I was telling you that everything's great and then it's not great. Um, there is hope. There are ways, to climb out of it. It's almost never as easy and fast as we all would, human nature would like it to be. Um, but it's not impossible, and it's not a black box where you just go and you just get sicker. There are ways to work on this. Some of the things like we talked about, there's lots of testing now that you can have done to see if this is one of your problems, and there's other things, the testing that can be done. So I guess, I talk to people every day who really are, you just become so dejected because you're sick, there's not answers, and you think, I'm never getting out of here. And what I would say is that there are ways out. They're not quick usually, but there are ways out. So there is hope, and a lot of what you're talking about is where that hope comes from. So I think I'd like to leave on a positive note, and that is truly it.
Yeah. And, I'd say to piggyback on that is, find a doctor and establish your team, people who are willing to advocate for you, and they're out there. It just takes some work and networking to find and establish the team that's going to, give you, help you with these resources. And so, thank you so much. This has been a delight, and I really enjoyed walking through this with you and just reconnecting.
Thank you. So this has been fun.
Excellent. Thanks. Thank you so much for tuning in to this week's episode of the One Thing Podcast. Please share these episodes with your friends, loved ones, colleagues, patients, healthcare providers, anyone who you feel might benefit from hearing these informative interviews. We tend to learn best from people sharing things with us. That's often the first time it's introduced. So don't hesitate, if the content of these episodes reminded you of someone that might benefit from it, forward the episode to them, and I'm sure they'll either appreciate it or be appreciative that you've thought of them. So once again, we'll look forward to seeing you next episode on the One Thing Podcast. And again, much appreciation for you being here with me.